We will hear from Mr. Alan CASSEL, who came to Réunion from his home in Victoria, on the west coast of Canada. Okay, Alan, the floor is yours.
Thank you very, very much. I will speak in English, though I could speak in French. Je peux dire bonjour. I am very, very excited to be here. When Philip asked me to come to Réunion, I had to look on a map of the world to find it. I had never heard of I'd have heard of it, but I didn't know where it was. I had to look on a map. The way I explained it to my children, if you have a globe and you found my city on the west coast of Canada and you put a long arrow through the globe, it comes out the other side in Réunion. So I'm exactly on the other side of the world. Phil didn't say very much about me, but I should probably tell you a few things. First of all, I've been studying pharmaceutical policy for almost 20 years. I'm a researcher at the University of Victoria, and I've written 3 books about the drug industry, the pharmaceutical industry, and their involvement in disease mongering. This was the first one that I wrote with Ray Moynihan. You might recognize that name. He was your guest last time at the first conference. And I should say as well, Philippe, that I'm very happy that the union, so for the people overseas who are listening to this, it's the union, the Regional Union of Pharmacists who have paid for my trip to come here. I'm doing this as a volunteer, and I'm not being paid. I'm doing this because this is a very important topic, and it's a topic that has a global significance. There are people around the world right now who are like Philip, who are people who want to change the world one small step at a time. There's people in Canada, in England, in Australia, in France, completely around the world who are working towards this activity. Phil, are you going to advance my slides? Okay, so if we can go to the next slide. So I just want to indicate that I'm not funded by any pharmaceutical companies. Just continue advancing the slides if you can. I haven't taken money from the drug companies, and so I'm independent that way. My salary comes from the University of Victoria and from work that I do as a journalist. Next slide, please. Well, okay. So in the next hour, this is what I'm going to talk about: selling sickness and disease mongering, the importance of medical independence, and I'll give you some examples of disease mongering from the new DSM, the Diagnostic and Statistics Manual number 5. And I'm going to talk a little bit about medical screening. This is the book that I wrote, which was published last year. The whole issue of medical screening, as you can imagine, is very controversial, and there are lots of reasons why we have to be very careful and very skeptical of medical screening. Next slide, please. When we wrote Selling Sickness, I found a quotation from a person named Henry Gadsden. He was the president of the company Merck, and he told Fortune magazine in 1976 his dream was to create drugs for healthy people. When you think about that for a second, what does he mean by that? Well, usually we think that medications and drugs are for people who are sick. His dream was to create drugs for people who are not yet sick. People who could be sick in the future, which means the potential market for products is everyone. And his dream was to sell, like Wrigley's. Wrigley's is a major chewing gum maker. His dream was to sell to everyone, like Wrigley's is chewing gum maker. Next slide, please. That's Ray Moynihan and myself. And I just want to say that part of the reason why we wrote this book and why we're interested in this topic is that the unhealthy influence of the pharmaceutical industry has become and continues to be, in my opinion, a global scandal. And that influence is fundamentally distorting medicine, it's distorting medical science, and it corrupts medicine. And it also affects the way your doctors think about disease and the way your doctors prescribe drugs. There's a definition of disease mongering. It's about widening the boundaries of treatable illness in order to expand the markets for those who deliver treatments. Okay. So how do companies do this? How do they get about selling sickness? How do they go about disease mongering? Well, they're very important at the start by creating and publishing the science behind medications. They publicize the effects of drugs, of treatments. They often use the media to exaggerate the effects. They hire what we call key opinion leaders, and those opinion leaders, their job really is to shape the thinking of other physicians, largely other prescribers. They sponsor disease awareness campaigns, and they involve patient groups, and the patient groups being, so all of these areas are affected by pharmaceutical industry, not just the money, but the shaping of how we think about disease. This is the kind of language when you see disease mongering, they'll say things like, there's millions of sufferers, there's an enormous burden of disease, 1 in 4 lifetime chance of getting something. So the risk is always portrayed as being very dire, very, very high. And then the follow-on is what's coming is a breakthrough treatments, new drugs, super drugs, tremendous therapeutic advances. That's the kind of language you would hear. This is an example in Canada where the pharmaceutical company that makes testosterone replacement therapy was advertising in major newspapers. They weren't even advertising the drug, they were advertising the disease. And in this case, the disease is low testosterone. Next slide, please. And the way you determine who has low testosterone, they gave a quiz like this that's published on a website, and it lists a series of questions. Do you sometimes lack energy? Do you sometimes have less interest in having sex? Are you sometimes sad or grumpy? These kinds of things, most men between the ages of 40 to 70 would answer yes to several of these, and the punchline is, go see your doctor. And the reason they use that punchline is because the pharmaceutical companies have already visited your doctor. They have already visited your doctor and explained to them the benefits of giving men testosterone replacement therapy and of checking their testosterone levels, prescribing drugs. Next slide, please. So these are just some examples, and I want to have a little bit of fun here. Some of these, I mean, all of these at the extreme end can be very problematic for some people. And for some people at the extreme end, drug treatment is the right thing to do. It's appropriate. But for most of the people in the middle who aren't quite sick, who would probably benefit a lot less, and they can be potentially harmed. And the kinds of things that have been, I think, created by the pharmaceutical industry are things like premenstrual dysphoric disorder, hypoactive sexual desire disorder, and so on. You can see the list there. Next slide, please. Here's an example. Now, this is a very interesting example of a drug which was sold in around the world. The generic name is fluoxetine, known popularly as Prozac. This drug is for depression. It's an SSRI drug. It was coming to the end of its patent life, and the drug company did something very, very clever. They tested it in women who had symptoms of premenstrual symptoms, and they determined there is perhaps some level of benefit. You can see you're taking something where there's the physical symptoms of menopause, and you're turning it into a mental problem. So they took the pill, they changed the color. Prozac used to be, Prozac is lime green and yellow. They changed it to pink and lavender. And so this drug was launched in North America under the trade name Serafem, and it's to treat this idea of premenstrual dysphoric disorder, which any woman could probably look at this advertisement and say, yes, that's something that I have. Next slide. So another example is what the industry has created as being hypoactive sexual desire disorder, okay? So in English, we would say, this is the drug for not tonight, honey, I have a headache, which is to say, women who are disinterested in sex have suddenly become patients, and they require medical treatment. And the treatment in this case is a testosterone patch. And you can see that the woman is wearing the patch right here on her stomach. And that delivers a transdermal dose of testosterone. By the way, this drug was never approved in the US. It was almost approved, but it was never approved. And Steve Neeson, who was one of the reviewers, said, essentially, I don't want to be exposing several million American women to heart disease and stroke in order to have one more sexual experience per month, because that was the clinical benefit shown. Okay? Another example of selling sickness is an older treatment or an older condition called what we call the menopause. And just advance the slides a few more. One of the important things here is that menopause, though if you're a woman and you live long enough, you'll go through symptoms of menopause. The question is it something that you need to be taking a drug, such as hormone replacement therapy, for the long term? And that was an idea that was very much pushed by the companies, and they used celebrities. And here you see people like Patti LaBelle and Lauren Hutton marketing the benefits of hormone replacement therapy. Okay, continue. And it was also something that was really started in the mid-'60s by this author, a person named Robert Wilson, and he espoused this theory that menopause is not a normal life change, it's an estrogen deficiency, and therefore, in order to fix yourself, you need to replace it with estrogen. And this is an actual quote from his book where he said, without estrogen replacement therapy, women are destined to become sexless caricatures of their former selves, the equivalent of a eunuch. The media is very important in selling the ideas about disease. And here, this is an advertisement which is advertising to pharmaceutical marketers, where the advertising industry wants the drug industry as a client. And so they say, come and put your articles, put your advertisements in my magazine. In this case, it's USA Today. It's the most widely read newspaper in the United States. So just some recent examples is the new DSM-5. And next one, please. And what we've seen in the DSM, by the way, is the Diagnostics and Statistics Manual, and this is the 5th version. It's come out just last month. It's very controversial because there are, again, many examples of diseases in there where it's clear that they're disease mongering. And the example here is around pre-dementia, where you've got people who say, well, is it something that we can treat beforehand? So pre-dementia, and this new category of mental illness known as mild cognitive impairment. So this is the first time that this label could apply to whole populations. And you have to ask yourself, if you sometimes forget things, you sometimes get a little confused, is that just normal life, or is that a disease? Is that a pre-disease, pre-dementia? Next slide. Another example is what we call cyberchondria. Have you heard this term, cyberchondria? So this is where if you're concerned about a disease, you're concerned about cancer or heart disease or dementia, and you go onto the internet searching frantically to find out maybe you have these symptoms or those symptoms, that action itself is being put in the category of being an illness. Okay, and Alan Francis, who was the authors of a previous, one of the authors of the previous version of the DSM, has been very critical and outspoken about this and said, you know, essentially 1 in 6 people suffering from cancer, heart disease, and other diseases, they risk being saddled with another one, which is a psychiatric disease, because you go onto the internet and you spend time looking up your symptoms. Other examples of pre-diseases. Now, this is part of the reason why I wrote a book about screening, is because screening is about finding diseases before they can strike you down. Okay, an example being pre-dementia, pre-hypertensive, having pre-diabetes, or pre-high cholesterol. So I'll give you an example of what happens in Canada. So just so you know, there's only 2 countries in the world that allow direct-to-consumer advertising of pharmaceuticals to the consumer. That's the United States and New Zealand. In Canada, it's not allowed, but we get a lot of advertising across the border on TV from American channels. And we also have homegrown examples of essentially advertising drugs, but they're not advertising the drug, they're advertising the disease. And a great example is, this is an example of an ad campaign that ran for quite a few months, major newspapers in Canada asking people, would you rather have a test, a cholesterol test, or a final exam? By the way, I put the French up in the corner here. The choices are not that stark. You're not going to die overnight because you haven't had your cholesterol tested. Next one, please. This will resonate with people in Réunion because occasionally people will get hurt by sharks. Here's a shark in a swimming pool, living with high cholesterol. You could be surprised what's lurking underneath. Okay. Again, this is an ad from an American magazine asking people to go out and, again, do something about your high cholesterol because staying fit isn't enough to stay healthy. Okay. This is an example of a drug ad campaign which is still going on in Canada. My colleagues in Vancouver have made complaints to Health Canada about this ad because this kind of ad, it's for a drug called Champix, a drug for smoking cessation. This drug comes with serious warnings around cardiac effects, around psychiatric effects. And here they are advertising it on billboards with the words, j'ai réussi, in English, I succeeded. It's about people trying to quit smoking by taking this drug, okay? Again, this is a bus shelter in Vancouver. And they're not advertising, what they're really advertising here is, go see your doctor. And besides, why would you go see your doctor? In this case, because the doctor can do one thing for you. They can write you a prescription for the blue pill, Viagra, okay? This is an example of an ad from in a magazine in Canada for Celebrex. Again, celecoxib. This drug is a sister treatment to Vioxx, which was probably one of the world's biggest drug disasters, even bigger than the Mediator scandal that we have ongoing here in France. Many people killed, injured by this drug. This is in the same category, and the drug companies are advertising it. Here's an example where they're planting a seed of concern, right? And it says there, sometimes there is another side to depression. It could be bipolar disorder, okay? This is really an advertisement to get people thinking that, well, perhaps you might be a candidate for an antipsychotic treatment. These are very powerful, very toxic drugs, and a classic example of disease mongering, where you're pushing it on healthier and healthier people, okay? And this is an example of an ad for Vioxx. This was one of the biggest drug disasters probably in modern history. And there, again, they don't even mention the nature of the disease. In this case, this drug is to treat arthritis. It's an anti-inflammatory treatment. And they use a famous figure skater. That woman is Dorothy Howell, okay? So you might say, okay, so the companies are disease mongering. The companies are pushing treatments on healthier and healthier people. But I should be safe because I have my doctor helping me. My doctor is looking out for my best interests and trying to keep healthy. But I can assure you, because the pharmaceutical industry, their sales platform depends on people like this, These are salespeople, the sales reps that visit our physicians and largely educate our physicians about medications. I mean, it's kind of absurd when you think about it. If you wanted to educate your physician about, say, alcoholism, would you send representatives from the beer and the wine industry to the doctor to educate them about that condition? I mean, it is kind of absurd. So the question, of course, is, are the pharmaceutical companies the best places to be getting drug information from? This is an example of a Canadian ad, which is in the Canadian Medical Association Journal. And they're advertising a drug called Avandia, essentially trying to get people to be concerned about their blood sugars and to seek this kind of treatment. What they're doing, though, in this ad is they're saying that this treatment has been approved and recommended by the guideline committees. Now, the guideline committees, heavily funded by the pharmaceutical industry, they produce guidelines that they say are very evidence-based, but are in fact quite biased and can be quite biased, and they really promote new, unproven treatments. This drug, by the way, is no longer sold in Europe. It's been taken off the market because of the safety concerns, and it's on the market in North America, but just barely. Okay, so what does the research say about the interaction between doctors and drug companies? Well, first of all, they spend an awful lot of money. Most of the marketing budget goes towards the sales reps who visit our doctors. About half of the money goes to free samples and to the sales reps, and most doctors believe that I can't be affected. For example, physicians, and this is what's important here, this is reported more than 10 years ago in the American, or the Annals of Internal Medicine, and they've said essentially, physicians frequently do not recognize that their decisions have been affected by commercial gifts, and in fact, they deny industry's influence. However, this is very well researched, and the research has shown that there is a very strong correlation between receiving the benefits of industry, meaning the gifts, the samples, the influence, and favoring their products, okay? And that's just an example. This is an older slide, but an example of where the promotional budgets go. As you see, most of it goes towards samples and to sales reps. Some of it goes to, this is direct-to-consumer advertising, meetings, journal ads, and unmonitored promotions. And a lot of that might be paying key opinion leaders to go and convince our physicians of the benefits of various treatments. So we did a study, and this, I just want to mention this very briefly, because one thing we don't know is what we don't know is how much information do our physicians get about drug safety when they're being visited by sales reps. And so we did a study. It was 3 countries, Canada, the United States, and France. We had partners in Toulouse, as you can see there. Next slide, please. And the kinds of things that we found, these were the kinds of drugs that were being heavily promoted. We found that a lot of them were actually drugs that had very strong safety warnings, or drugs that were about to be removed from the market because of safety problems. And you see things like Vioxx, Avandia. Not all of these drugs would have been promoted in the course of the study that I'm talking about, but this is the kind of thing that we saw, is that even drugs that had very serious warnings were being promoted to our physicians, and almost never in a way that's balanced. Next slide, please. This is an example of Avandia, the diabetes drug. You can go to the next one. So what kinds of things did we find in the study? I'm going to be very brief about the conclusions, is that over half of the time when the sales rep is visiting the physician, they don't mention safety at all. Don't mention the potential problems of the drug. And in less than 5% of these promotional visits, would have anything about the serious, or we group together what we consider to be basic minimal safety information. So these would be the side effects, the adverse effects, the contraindications. And of those things that were mentioned in the sales rep visit, about 5% of the time there would be some mention, okay? So let's talk about gifts. So the gifts, in my opinion, we actually have a different regime here in France, and I understand there's a new Sunshine Act. This is similar to the Sunshine Act in the United States. The one major, I'm not an expert on the Sunshine Act, but what is asking physicians to do, and actually demanding physicians in the United States to report any gifts that they receive, any money that they receive. And the reason is that they want to have a public record of how much influence the drug industry is having on prescribing. The difference between the Sunshine Act in the US and the one that's coming into France is that the one in France doesn't affect the key opinion leaders. So really the specialists and the more senior physicians who are perhaps academic physicians and so on aren't required to have the same level of reporting and telling, reporting of their conflicts of interest. And so that's seen as a major drawback. We'll see whether the Sunshine Act works in the US. It's coming in next year. This is probably one of the most shocking pictures that I've ever seen related to the practice of medicine. This was on the front cover of the major medical journal, the British Medical Journal, and this was published back in 2003. So this is a decade old. And in this, there was a series of articles by my colleague Ray Moynihan about entanglement. He called it entanglement between the drug industry and the practice of medicine. And he had another article about disentanglement, how to separate ourselves, how to become medically independent. I think it's one of the first examples in a major medical journal where they're really worried about the credibility of medicine because of this kind of thing portrayed here. And just so you know what's happening in the photo is that you've got a bunch of people sitting around a table eating, gorging, and they are portrayed as pigs. Les cochons, okay? And you have people in the background who are the salespeople. They're portrayed as lizards, okay? And you've got the airplane indicating that they have been flown to an exotic location for this activity. You've got the lizard and the pig playing golf in the background. And the one person in the photo who's the patient, by the way, everyone in English knows what the phrase guinea pig is. A guinea pig is how they used to test most drugs on guinea pigs. So the patient is portrayed as the one guinea pig in the corner, looking dejected and really left out of the conversation. Okay, so just a very quick, I'm sorry I'm using too much time here, Phil. Very briefly, a little bit about screening. Next slide. I'm going to talk just briefly about cancer screening, okay? You might say, what's the problem with screening? Looking for something beforehand. And probably the major problem is that screening finds a lot of things that are never going to hurt you. We're talking breast cancer screening, prostate cancer screening, lung cancer screening, all kinds of screening can be done. It can find things. But the people who go through the screening typically don't live longer than those who don't. Okay, next. Back up, please. So essentially, what is the problems with looking for this? Well, you sometimes find what is called pseudo-disease, stuff that might look like disease. These might be calcifications in your breast. It might be an elevated level of a prostate antigen in the blood of a man. And therefore, when you go on the hunt, by the way, this book is subtitled Medical Screening and the Misguided Hunt for Disease. When you're on the hunt for disease, what happens is that physicians will typically prescribe, if you have a positive test, more medications, more procedures, all of which have some risks, and all of which represent often a huge waste of healthcare dollars. Okay, in fact, Dr. Gilbert Welch, who wrote a very good book about overdiagnosis, he essentially said that more than 2 million Americans have been unnecessarily treated for prostate cancer. Unnecessarily, okay? And in the US, the biopsy, where they go in to test the prostate to find cancer cells, there's more than 1 million American men every year that have biopsies, and about 4 to 5% of them will develop serious infections, serious enough to be hospitalized and made very sick. Okay? Some basic lessons about screening. You know what? These slides are going to be available on the internet afterwards. I'm just going to zip through this, okay, because I want to get more questions. Just continue, please. So what are the antidotes? How can we protect ourselves from disease mongering? Luckily, we have a number of independent groups around the world. We've got people like a group in Australia called Healthy Skepticism. You've got Medocean here in Réunion. You've got La Revue Prescrire in France that produces high quality information about pharmaceuticals. There are pockets of healthy skepticism around the world, and I think we need to nurture those. We need to use those. We need to promote those. Continue, please. And we have to be skeptical. We have to ask ourselves when somebody's coming at us with a new disease, you know, is this a real disease? Is this a real disease that requires a medical intervention? And then does it require a medical solution? And if it does, how does it compare to other things? How do the risks and the benefits and the costs compare? I think this is an excellent quote by Peter Mansfield. He's the creator and the starter of Healthy Skepticism, a group in Adelaide in Australia. And he said this a number of years ago. He said, finding good quality information on drugs is like finding a needle in a haystack. Drug marketing just makes the haystack bigger, okay? Speaking of independent groups, there is an organization called the ISDB. This is the International Society of Drug Bulletins. An excellent source of good quality information about drugs. In my opinion, only the best producers of quality information about medications are allowed to join this group, and you're lucky that you've got La Revue Prescrire as a member of ISDB. Excellent source. They typically work in English, but there are groups, independent groups around the world, including one in where I come from called the Therapeutics Initiative that is a member of this group, okay? So this is my final point, is that when we wrote this book, we said at the end, what do we really want to accomplish? What's our goal? And the goal is to start a global conversation about disease mongering, about selling sickness. This book has been translated into 14 languages, including Chinese, as you see here. And it's really very heartwarming for me to see that global conversation that we helped start almost 10 years ago has been carried on and picked up by people like Philip and others here who have lots of energy and lots of good ideas about countering disease mongering. Next, please. I just had to throw this in there because Mark Twain once said, be careful of reading health books because you may die of a misprint. So I'm just saying that as a warning to you. Last slide. So people wonder, what do you do when you're not talking about disease mongering? So this was taken when I was camping a little while ago. This is, in the background is Vancouver Island on the west coast of Canada. And I'm on the island with my family playing the guitar. My wife and my friends are playing the fiddle. My daughter's sitting there and my friends are taking pictures. Okay, that's the end. Thank you very much. I appreciate it. I take any questions, and if there's any in the audience, whether you're in England or in the United States or in Canada or Australia, you can send your questions in, and I'd be happy to answer any questions.
Thank you very much for your presentation. It was very, very, very interesting and very, very persuasive as well. From your opinion, are there countries that are more affected than others by drug mongering? And if so, which are they?
Okay. Do you want to translate that question, or should I just... Okay.
C'est simplement,
Okay.
d'après ce qu'a dit l'auteur,
Okay.
Sorry, English.
Sorry, no French. So, in my opinion, I think probably the worst in terms of disease mongering happens in the United States. You know, what's very interesting is that here you have a Canadian and an Australian writing a book about the American, largely the pharmaceutical industry in the United States. And part of the reason why is that they are not, because they don't have a functioning public health system. It's free market rules, the free market rules. So you've got lots of influence on politicians. You have lots of influence through the media. You have lots of direct-to-consumer advertising. And I think that really shapes how people think about drugs. The average American consumer watches 14 drug ads per day. Okay? 14. So that does a lot of an effect, I believe, psychologically, on thinking about what is health and thinking about what is sickness. I could say a few words about how I think France is great and how, certainly compared to the United States, I think at least in France you do have substantial public investment in drug safety and in pharmacovigilance. You have a review, prescrire, and other things. Other questions? Yes.
So you explained that in the United States, drug industry advertises the disease to sell drugs. But in a way, it seems to be very exciting because we have the illusion that the difference between the body and the soul may disappear, and that it may fulfill a human desire, you know, because we may have the sensation that we can control our body and that it's not a stranger anymore. It's not a burden. So it will be very hard to fight drug industry because the human desire is very strong, yes, according to that.
Absolutely. So if you ask, if the pharmaceutical is selling sickness, who is buying it? Why are we vulnerable? Why are we willing to absorb these messages? And part of it is because we are surrounded in many ways by worry, by concern about the future. And the one thing that's very important to all of us is the future of our health. So we're automatically very vulnerable. But the problem with allowing the pharmaceutical industry to be involved in shaping illness is that they're always going to tell us there's something else to worry about. There's something new to worry about. Low testosterone, breast cancer, prostate cancer. There's something new to be worried about. And I think that they have been very effective because a lot of us will not stand back and be skeptical and say, that doesn't make sense. That doesn't fit my psychological vision of things. I don't know if that answers your question, but
yes, thank you.
Okay.
Oui, je ne suis pas capable de poser ma question en anglais. Elle traduira en même temps.
Any other questions from the audience? Okay.
Yes, you said that one way to influence the medical decision for the industry is to sponsor an important study which are published in a very recognized review. The problem is that now it is quite impossible to have such study very important, including many patients and very, very expensive study without the sponsoring of the industry. And there is many examples for where study could not be done because the product, because the medicine is not expensive enough.
Absolutely, and that's part of the reason why we need public investment in research. You know, for example, there are some people that say something like vitamin D has a lot of health benefits. You know what I'm talking about with vitamin D? So But who is doing the big studies, the big important studies to prove the effects of vitamin D? Those are simply not funded to the same level as you would have done by the pharmaceutical industry. So you're absolutely right. There are some treatments that don't get studied because you can't patent them, because you can't produce a license to sell that drug and to charge a high price. So it is a fundamental distortion of really what we see coming out of sort of the medical products industry, is a real emphasis, I think, on patented products produced by the drug companies. Okay.
We have a question from Madame Danielle Bro, which asks if the disease mongering make the university to propose a program for the doctors, the young doctors, to resist the industry, pharmaceutical industry?
There actually are some examples of medical schools where they will not allow the pharmaceutical industry inside the doors to influence the students. We had actually a very good study in Canada a number of years ago where they compared. It was a study of the medical school at the University of Toronto and the medical school in McMaster University in Hamilton, two big important medical schools. And the University of Toronto allowed the students to have lots of, they went to do drug lunches and had a lot of contact with salespeople. And the people in Hamilton, the students, were not allowed. They disallowed it. And then they followed them over several years. And guess what they found? They found that the students who came from McMaster University were better prescribers. They actually thought more about, they wouldn't jump on the new drug right away. They would think about all of the other things that they should be thinking about, doing what we expect as patients, I think. So yes, I don't know if that answers your question, but the effect in medical schools has really been recognized, I think, around the world as a big problem. Because if you allow the young doctors to be influenced, that begins a habit that will last possibly the rest of their lives. But if you start the habit properly and say, we need a clear line between marketing activities, drug industry activities, and medical education, if you can draw that wall, if you can do that early, I think it's very, it will pay off.
Perhaps
Okay.
last questions, because we have to finish. I'm here.
Yeah.
To finish this English section. My question is about Canadian patients. Are they concerned and conscious about overdiagnosis and overtreatment?
Very good question. I don't think they are concerned enough. Let me give you one example where the concern about overdiagnosis has been really prominent. There was an article in the Canadian Medical Association Journal last year about mammography. So this is about breast cancer screening. And that article essentially said, it was written by Peter Gauthier from the Cochrane collaboration in Denmark. He essentially said that the benefits of mammography, in terms of preventing death, are quite small. The harms, the potential harm to women, can be quite large. And he asked the question, which country will be the first country in the world to stop mammography screening altogether? Essentially saying it should be Canada. Canada should be the first one to stop mammography screening. Okay, we have someone on Skype here. Maybe I should stop my... but yeah, the reason I mention this is that there is a concern of overdiagnosis, and the people that promote screening are starting to pull back. They're starting to say, let's be more careful about who we recommend for screening. It used to be you had to start a woman at 40. Now it's you start them at 50. So there has been changes over the years, yes.
Okay. Thank you very much, Mr. CASSEL.
Okay. I'd be happy, by the way, I'm staying here all day if other people have questions. Hi, Agnes.